Hello, good morning, everybody. This is Kelly Sandaker, SURSAC Administrator. We are going to be starting in just 1 minute. I just want to give just like 1 or 2 more minutes just to make sure I get everybody online. And so for right now, if any of the SURSAC committee members would like to just take a moment and with your full name and area representation and it'd be nice to see who's online and everything like that. We're just going to give another minute or two for people to join. Thank you so much. Okay, good morning, everybody. I'm going to go ahead and get started. I'm going to go ahead and read off our slides like usual. This meeting is being recorded and live streamed on TVW. The meeting recording will be shared on the HCA website on a page dedicated to SURSAC meeting information. The meeting recording is open to public and disclosure requests. Please do not disclose any private or confidential information. We will no longer use a verbal roll call so that we may use that time for other agenda items. However, we ask SURSAC members that you take a moment to enter your full name and the area of representation you serve on the committee into the chat so we can all be reminded of the wide range of representation we have within the committee. Language and terminology, use people first language, i.e. a person experiencing homelessness rather than homeless person. Use the term substance use rather than substance abuse or addiction, which is stigmatizing. Avoid using the term addict, person first language alternative, person with a substance use disorder, or person who uses drugs. When someone forgets to use these terms, assumes that their intent is still good, and be gentle with reminders to use agreed upon language. Resources, words matter, terms to use and avoid when talking about addiction. Guidelines for public feedback. We will usually allocate 10 minutes at the beginning of the meeting and 5 more minutes near the end of the meeting for public comment. Each person will have 3 minutes to provide feedback. Public comment on each agenda item will be invited after the committee has provided its comments, ensuring the dedicated time for public input before moving to the next item. If you are not a committee member and would like to comment during a discussion, please raise your hand to bring it to the facilitator's attention. Feedback that is not provided during the meeting can be submitted via email at any time to hcaesb5476@hca.wa.gov. And I just want to pull up the agenda for everybody. And just to notate, the agenda is looking a little different because we've added a few things to the agenda now. You can click on the agenda and you can get to our norms and expectations on the SURSAC website. You can also, if anybody has the agenda and for some reason they're unable to join Teams, they can join through TVW, though you will be limited and you will not be able to use the chat or speak through TVW, but you'll be able to watch if you'd like. And then we also have the full address and such as well. And just want to go ahead and now pass it over to Tony.
Yeah, thanks so much, and good morning, everybody. Kelly, can you zoom in just a little bit on the agenda?
We're worried about her.
And we have some. Yep, there we go. Thank you. Yeah, good morning. Happy February. I want to start off with just thanking everyone for showing up today with the inclement weather and the road conditions and everything. We're grateful to be able to have a virtual option for the SURSAC meetings. As you can probably tell, we're not in our typical Cherry Street Plaza Healthcare Authority conference room for today's meeting. And so we will be holding it all virtual, and then with weather permitting, move back into having an in-person option at our next meeting in March. And so with that, I just wanted to just take a moment to acknowledge and show appreciation and thanks for all of the critical programs that are out there that are serving individuals who are experiencing homelessness. Considering the way the conditions are inclement weather, having programs like HOST, Homeless Outreach Stabilization Transition, and Recovery Navigator program and LEAD, programs that provide outreach services within the community, is just so important to ensure that we're engaging with individuals that are currently experiencing homelessness and and having to do that in the snow. I can't imagine how difficult that may be, and I'm grateful and just for all the work that the direct service providers are doing during this time. Since the last time that we met, there's been just a couple of changes in terms of HCA leadership that I just wanted to flag for everyone. Um, Mary Ann Lindeblad has been announced and noted as our interim director at the Healthcare Authority. I think that happened back on January 9th, so a couple days after our last meeting. And so just great to have Mary Ann Lindeblad in an interim role while the governor's office looks for a permanent appointment for Healthcare Authority leadership. And then just you might have noticed on the agenda that the governor's office representative for SURSAC is still to be determined. So that was previously filled by Amber Leaders, and with the change in administration, we're working with the governor's office to identify who will be filling that role on SURSAC going forward. Want to talk just real briefly and just acknowledge the fact that last week was really difficult in terms of hearing federal news come down regarding the freeze of programs and federal grant services. As many of you probably know, since that announcement came from the Office of Management and Budget at the federal level, the memo itself has since been rescinded. And there have been two subsequent orders from federal judges basically halting some of those services or some of those guidelines and some of the action taken under those memos. However, we're still trying to kind of understand, we're tracking the situation at the healthcare authority level and understanding what this means and how it could possibly impact programs that are funded through the healthcare authority and Division of Behavioral Health and Recovery. And if once we know more and once there's something that is definitive, we'll be certain to share that out with any partners that may be impacted by that kind of changing situation. It's constantly evolving, and we're still just monitoring it and trying to understand what it means. And as of right now, there's no definitive impact on our programs or programs that are funded out of federal grants, at least with Division of Behavioral Health and Recovery. So no concrete update for that. A couple of other updates regarding the legislative session. Two legislative reports have been submitted since the last time that we met. Just want to remind everyone you can access those through the Healthcare Authority website. I'll throw that in the chat real quick. And that link did not transfer for some reason. If somebody could put the link to our legislative reports in the chat, that would be great. But the Safe Supply Work Group final report and recommendations was submitted to the legislature and other appropriate committees. And just a reminder, that was a recommendation that came out of the SURSAC and was included in the Substance Use Recovery Services Plan. The work group met and identified recommendations as to what a safer supply model would look like in the state of Washington. So really having as many options for individuals who are using fentanyl and other opioids and might have developed an opioid use disorder, and ensuring that there's a full continuum of services for to help support those individuals. In addition to the Safe Supply Work Group report, the Substance Use Disorder Intake Screening and Assessment Services Work Group recommendations was also published. And so got those recommendations and legislative reports submitted as well. And again, that work group also came from the Substance Use Recovery Services Plan. So it's great to see some of these things that we've been talking about for years now kind of come to fruition. And as a reminder, that work group was looking at how we can streamline and improve the processes associated with getting somebody care and engaging with them at the intake, screening, the various ways, and looking at the barriers, significant barriers to being able to help somebody and leverage Medicaid immediately, and what that can look like. So you can also find that report at the link that Kelly provided in the chat. I think we have a little bit more time, and hopefully, and we can use some of the committee member announcement and comment time for any questions on. I know I'm kind of dropping a lot of information out there, but I wanted to flag a couple of bills that are scheduled for public hearing in the next couple of days. One is House Bill 1427. This is looking at ways to expand the peer specialist work across Washington state. There is a section in here that directs the healthcare authority to contract with an external entity to develop proposals around creating low barrier and cost-effective opportunities for service providers to bill health carriers for behavioral health services that are currently funded by the state general fund, including LEAD, Arrest and Jail Alternative, Recovery Navigator Program, and HOST. So really looking at how we could possibly leverage Medicaid to fund some of these services that were funded back in 5476 after the State versus Blake decision in 2021. And so that is scheduled for a public hearing in the House Committee on Healthcare and Wellness tomorrow at 1:30. Note that could be subject to change, but at least as of last night when I was kind of putting this together, that's when it was currently scheduled. So I can put that bill number in the chat as well. Well, I don't know. The last time I tried to do this, it didn't work. Let's try this again. There we go. So that's House Bill 1427. We also have a public hearing coming up sorry, I have to scroll down. There's a lot of pending bills. Senate Bill 5031 concerning healthcare coordination for confined individuals. Establishes a new council within the Department of Health that will be supported by representation from a number of state agencies, local parties, people with lived experience, and it will look at coordination and communication around the services for individuals that are currently incarcerated. So that is scheduled for executive session in the Senate committee on the 5th at 8 a.m. And I don't have the link to that one, unfortunately, but it's Senate Bill 5031. So maybe somebody can kind of pull that one. One more, it's scheduled for public hearing today at 1:30. It's House Bill 1113. I'll put that in the chat, but maybe somebody can actually link to the report website. But this one is concerning accountability and access to services for individuals charged with a misdemeanor. They're calling it the Safety Act, the Public Supporting Accountability and Fast Effective Treatment Act. It authorizes the court to dismiss a defendant's misdemeanor or gross misdemeanor upon substantial compliance with court-ordered conditions. It's scheduled for public hearing today at 1:30. And I think that's it in terms of ones that are today or the next couple of days. So just wanted to kind of flag those. We know, Kelly's doing a great job sending out a list of all the pending legislation. Just a reminder, that's not, we try to have it be as comprehensive as possible. We want it to be helpful. And so if there's any feedback, from the committee members about what else would be, we could include in that, or if you want us to like highlight certain ones, the list is getting long. And so at some point we may want to at least try to, highlight which ones are still kind of moving through the legislative process, or at least appear to be so. And so feel free to share any feedback or how we can kind of help improve with communication that we're getting out there. With that, I think we're right on time, but sorry I went a little bit over, and I know that was a lot of information trying to capture a lot, and a lot is happening. And so with that, I'll pass it over to Blake for the next. Oh, well, I didn't review the agenda real quick before Blake, 1 second. Agenda, we got a great agenda today. We have the Lead Support Bureau coming and presenting on the LEAD model and what law enforcement assisted diversion looks like. We also have our guest Recovery Navigator program from Pierce County, Ani King with the Carillon Behavioral Health Administrative Service Organization, and I believe a direct service provider will be joining us as well. And then we also have Cooper Wright to come and talk about some of HCA's data strategies, what we're looking at in terms of data collection and data storage and what that looks like. So with
Tony,
that.
What time is the House Bill 1427? You said it was today? Oh, somebody, thanks, Kelly. Never mind.
Yeah, Kelly, is it in the chat? I was looking for it. Oh, awesome. Thanks, Kelly.
It is February 4th, correct, Tony? Tomorrow?
That one's tomorrow. There is one today. I forget which one.
That was the House Bill 1113. You said was today at 1?
Yes. Yeah, thank you. Okay. Blake, if you want to bring us into the next agenda item, that'd be great.
Good morning, folks. We have on the agenda rather an opportunity for committee members to giving kind of announcements or comments they have to start us off today. So does any member of the SURSAC committee have anything that they want to announce or any comments they want to make? Go ahead and raise your hand virtually. Caleb, please.
Good morning. I want to make sure folks are aware of House Bill 1574, which addresses several things that happened in the Blake bill. I think I've got that correct, including issues around safe smoking materials and the types of entities that are allowed to distribute those. Works to expand Good Samaritan protections. That's actually a much older bill that it's working on there. It is also working to more explicitly protect clients of drug checking programs. And lastly, quite importantly, tries to address the sort of local ability to usurp or block harm reduction programming. So just aware of that. I think it's going to be heard next week.
Okay, thank you very much. Any other committee member that would like to make an announcement or has any comments? Go ahead and raise your hand.
Just thinking about, there's a lot of legislation moving through, and I don't know if it would be helpful to the committee, but we could ask for somebody from our legislative affairs to come and just do a quick rundown next month of at least as of March, whenever our meeting is, like kind of which bills like passed any cutoffs. I forget if there are any cutoffs between now and then. I think there is one. But what's currently kind of moving at that time, we can try to dedicate some agenda space for that, just to have a little more in depth. And based on the chat responses, it looks like at least March 12th is the House of Origin. Thank you. So there might not be a House of Origin cutoff. I think there might be a fiscal cutoff before then. But it looks like Nikki and Addie and Julian indicate that that might be helpful. So Kelly, maybe we can, while kind of putting together the, thinking about the March agenda, setting aside a time for that. It'll be a lot more thorough and more well done than me kind of rambling through several bills.
I have it noted, Tony.
Awesome.
All right, thank you. Any other comments from committee members? Malika.
I was just wondering if it's okay to mention some bills that are not necessarily directly related to health, but would deeply impact the folks that we are organizing around and having this group meet for?
Please go for it.
Okay. So House Bill 1185, 1235, and 1380 are all bills that would help people like stabilize in their life. One of them is a rent stabilization bill. The other one is a universal basic income bill. And I believe the other one helps families get more representation, like kinship families, to be able to get more representation when they're trying to work with the children that are potentially going to be removed from somebody in their family. So those are just things that it would make sense for us to, support as far as like people having more access to legal income. Decreases the amount of crime that's occurring in our communities. So just things to think about.
Malika,
Thank
could
you.
you put those in the chat?
Yeah.
Thank you, Malika. Appreciate that. Any other comments from committee members or announcements?
I just wanted to say, Kelly, maybe we can make sure that those ones that Malika just shared and that we add those to our list, kind of our tracking list.
Yeah, I can do that. And whatever you put in the chat, Malika, I'll go ahead and link the bills and everything. So if you just put the numbers in, I'll put the links.
Okay. Can I do it after the meeting? I'll send them to you. Does that work?
Yeah, that's fine
Okay.
too. Yeah.
Thanks.
Okay.
And real quick, it looks like there's just a couple of questions in the chat. First, from Hunter, does anyone have a strong idea as to how things are going in Oregon? I have heard a lot of critique online on most fronts concerning legalization, decriminalization trends. It's a good question, Hunter. I honestly, with so much stuff happening in Washington and nationally, I'm not certain kind of what Oregon's recriminalization of simple possession, what that looks like. I know that they were providing grants, community grants or county-based grants, and there was kind of flexibility in how the counties were using those, or the different regions. But that might be something we could also look at, if there's interest, having somebody from the Oregon Health Authority, or I think the oversight of that actually moved to like the Oregon Criminal Justice Commission, if I remember correctly. Like Oregon Health Authority did have oversight on some of the regional hub work that was happening when there was decriminalization, and then when recriminalization happened, it kind of got shifted to the Criminal Justice Commission in Oregon. But we can find out and have somebody come and provide a comprehensive update. I think it makes sense to kind of track what's happening to our neighboring state while we're kind of dealing with a lot of the same issues. And then Nikki indicate, and then well, let me get to this next one, and then if anybody has any kind of additional comments from the committee, or if that makes sense or not, let me know. But Nikki indicated interested to hear more about 5229, which seems like it could be extremely harmful to substance using people. Yeah, Nikki, good call. 5229 widens the definition of gravely disabled for our Involuntary Treatment Act to include individuals. And there was a substitute bill that changed it from 180 days to 2 weeks, but basically adds to gravely disabled that individuals would be classified as gravely disabled and subject to involuntary treatment if within the 2 weeks prior to that person's detention, they had required revival by opioid overdose reversal medication to prevent a fatality or probable fatality. It passed out of the committee and was referred to Ways and Means, which would be the fiscal committee. And so it is kind of moving its way through the legislature. And so thank you for flagging that one. And Kelly has a link to that if anybody is interested in reading the legislation.
All right. And Caleb, you put something in the chat, a link in the chat. You want to mention what that is?
Oh, that's just a somewhat older article looking at Measure 110. I think folks are familiar. We heard the same confusion in Washington State, conflating drug policy with mortality rates. As we all know, mortality rates were on an upward slope well before our local legislation happened. And so this was looking at one of the arguments in Oregon. So it's somewhat earlier, lighter touch evaluation. But I think the broader issue is, and I actually have a question into Kelly, hopefully getting to get those data, is, you can change a law almost instantly. You can change infrastructure over many, many, many years. And so differentiating a policy failure from an implementation failure is essential. And I think that those have been challenges in both Oregon and Washington, maybe more with the rhetoric than reality, but I do think it is important. And I do have a question in that hopefully we can see this data. I have not been able to track in these meetings how long it has taken us to scale up our services, and concomitantly what the utilization has been like. What is that timeline? I think it's several years. And so it'd be helpful to see that as we're starting to think about the so what and opportunities for improvement.
Thank you. Okay. Any more comments by committee members? All right, let's move to public comment. Any member of the public that would like to make a comment, please go ahead and raise your hand at this point virtually, and we will call on you for comment. Last call for public comment. I see no hands. Let's go ahead and move on to the next agenda item. Tony, did you want to introduce the LEAD Education Series Part 1? Tell us a little bit about what's going on there.
Yeah, absolutely. And I was smiling because I think Kelly, just a heads up, when you share your agenda, you might also be sharing your screen that has announcements come up. And so just kind of flagging that. But anyway, that's why I was laughing or smiling, or at least grinning to some extent. Yes, this was something that came up during our mural exercises. As everyone may recall, committee members as well as those who attend this from the public and our guests, we did a mural back in December. It was really fun. Everyone had a chance to move little sticky dots around the mural to identify kind of what our priorities or where we want to focus some of the educational opportunities for the committee as well as for guests and public members. And then this was one of the top voted ones, was basically a kind of LEAD series, a series from the LEAD Support Bureau on what the LEAD model is. We talk a lot about LEAD and Recovery Navigator Program and Arrest and Jail Alternative, and talk about things like pre-booking diversion and what does that mean, and how are we engaging with individuals at the intercept one of the sequential intercept model and trying to ensure that we're keeping them out of the criminal court system, where it is much more costly and less efficient to address substance use disorder and behavioral health and the situations that arise from untreated behavioral health disorders. And so with that introduction, I'm going to hand it off to the LEAD Support Bureau, who have graciously volunteered their time and agreed to kind of put together a kind of a series. I think we're looking at 2 to 3 part series that kind of really looks at this model, talks about evidence and some of the outcomes and the origins. And so with that, I will hand it over to our guests, and thank you so much for being here.
Lee, I'm sorry, just leave real quick. Just tell me next slide and I'll move it on to the next slide whenever you're ready.
Thank you, Kelly. We'll do that. And thank you, Tony, for that gracious introduction. Next slide, please. Hi, everybody. My name is Malika Lamont, and I'm the director of the Washington State Technical Support Team at the LEAD Support Bureau. I came into this work as a project manager with Purpose Dignity Action, the overarching agency that houses the LEAD Support Bureau. However, the issues that LEAD hopes to address have been impacting my family, sadly, for generations. And I have a history working as a family crisis response worker. At one time, many moons ago, I was a licensed counselor, and I have worked for quite a few years in harm reduction, providing direct service through syringe exchange programs, as well as doing advocacy and policy. And I'd like to hand it off to my colleague, Brandy McNeil.
Good morning, everyone, and thank you so much for having us. My name is Brandy McNeil. I am one of the deputy directors here at PDA, and just by way of background, my background is as a long time, I guess now it's only the first half of my career, but I was a public defender first in DC, and then in New Orleans for 3 years, 3.5 years before I moved out west. And that really, my experience as a public defender, but as, you know, a member of sort of the criminal legal system and seeing how it works and why it is important that, you know, each part of that process works as optimally as possible for public safety, I think has really informed my view in my work as deputy director. And so as deputy director, I am over, I help supervise the LEAD local team, which includes a small but mighty legal team. It includes LEAD in Seattle and LEAD in certain areas of South King County. So with that, I'll hand it off to Naja.
Thanks, Brandy. Hi, everyone. It's nice to virtually meet you. My name is Naja Morris Frazier, and I am the director of the LEAD Support Bureau, which is the national side. So while Washington State TA works primarily with all the sites in Washington, the LEAD Support Bureau national side works with all the sites pretty much outside of Washington State. So I have been with the Bureau now for almost 8 years. I started my work with the with LEAD entity back in 2013. I was a case manager and a supervisor in the pilot program there in Seattle. And before I came to this role, before I started working with LEAD in 2013, I spent about 20 years working in the Seattle area with youth at risk, families at risk of eviction. I did adult, family, and adolescent treatment. I also worked a lot with young people who were in the foster care system and who were at risk of incarceration in the disproportionate juvenile legal system and criminal legal system that also exists in the city of Seattle. So it is nice to be here, and I'm glad to be able to share with you all more about the LEAD program. I will kick it back to Malika.
It's back to me, actually. So next slide, please. Okay, so you know, the challenge that we're facing right now is that communities across the state are facing, you know, the growing challenge of addressing behavioral health and public safety concerns. And, you know, not only has the traditional approach of arrest and prosecution alone fallen short and further harmed many members of the community, but local legal systems are facing an unprecedented backlog, right? Court systems are bogged down, public defense is bogged down and overwhelmed, you know, especially with, you know, potential changes in caseloads. Suddenly more public defenders are going to be needed. And then, excuse me, law enforcement is also totally overwhelmed with many, you know, systems finding themselves short-staffed and really trying to figure out a path forward. The fact is that, you know, because of for those reasons, state leaders are calling for deeper investment in public safety, and local legal systems simply cannot and should not absorb these issues. Next slide. LEAD is designed to respond to the present moment by presenting an alternative path, a transformative shift towards community-based solutions that achieve real, durable public safety outcomes and can and do work under current conditions. LEAD achieves this through a collective impact approach. So individualized, trauma-informed, trauma-responsive case management paired with system coordination across police and other law enforcement, prosecutors, social workers, and civil rights groups. So really, you know, the innovation here is that LEAD really brings all of these different disparate people into one room. Often, police and prosecutors might be on one side, and social workers and civil rights groups are on the other. And what LEAD does, and where it is innovated, is brought those individuals all together for the good of, yes, the individual participant, but with the ultimate goal of making the public, the community, safer. And LEAD is a pre-booking diversion program, and it's designed to serve individuals who are exposed to enforcement. And it operates upstream. So the thinking being intervening prior to the booking, prior to deepened harm, and in a way that ultimately makes it less likely that that person would need to be arrested or put into the criminal legal system. I'll hand it off to Malika. Next slide.
Thank you. I think many of us in Washington State, especially on this particular group, can agree that we have had a lot of policy changes over the last few years. And the LEAD model has been something that has been constant through all of them. The LEAD model was initiated in 2011 when simple possession was still a felony. And then in the moment that we experienced in 2020, when we had a social uprising where people said we wanted something different, and in 2021, and when we experienced the Blake decision, there was no consequence. And then we had a misdemeanor, and now we have a gross misdemeanor. The beauty of the LEAD model is that it brings the potential for something more to happen with people that are really struggling. And no matter what the policy environment is that is occurring, LEAD introduces an opportunity for the system to function differently and learn how to do something that is potentially more effective. Law enforcement can refer folks that they continually come in contact with, and they can do that as a social contact referral. The community can refer people in as a community-based referral. I think we've recognized on multiple levels and multiple times that we can't arrest our way out of this. We can't prosecute our way out of the circumstances that we find our communities in. LEAD interrupts this process by pairing intensive long-term case management with systems coordination amongst all stakeholders, law enforcement, prosecution, social work, and civil rights groups. And the resulting collaboration is greater than the sum of its parts and generates greater outcomes than any siloed approach could. For this reason, active participation from all partners is a non-negotiable. This is why fidelity to the model is so important. For example, the operational work group, which is the group of people that are on the ground working with people, may oftentimes notice where certain policies may be interrupting the ability to best meet the needs of participants and the community. And they can feed that information up to the policy coordination group, where there are decision makers from that community, from the legal system, as well as from law enforcement and defense, and people that may be running some of the services that are available in the community. And that feedback can result in a changing of policy that makes it so everything works better for everybody. Housing is often the missing piece. We leverage it wherever and whenever possible. Innovations like CoLead and the Right-of-Way Project and encampment resolution are all a clear example of what's possible when you take the LEAD model and then guarantee access to shelter and lodging by design. Next slide, please. LEAD enhances safety through robust multi-sector collaboration, aligning community resources and advocates for more equitable, people-centered, and long-lasting impact. It requires that partners align resources in new ways. So for example, I was mentioning earlier, something may bubble up from the operational work group. For example, in some places, there may be shelters that are like, you have to be not under the influence of anything and sober if you're going to come in and use our shelter services. And sometimes that results in communities having empty shelter beds that people could be accessing, but everybody's still outside because of that one policy. That creates an opportunity for the OWG to take that feedback, the operational work group, to take that to the PCG and say, hey, so, people can't get into, we understand there's beds. We understand the community's frustrated because people aren't using those beds. However, this is the policy that is creating the issue why people are not going inside. And then it can bring forth a conversation. It may not change every time, but at least it starts a conversation and it starts communication, and issue identification starts to happen, and communities can then in turn be responsive. And maybe that means that there's another shelter that opens up that doesn't have the same policies and that is able to be supportive of the people that haven't gotten to abstinence yet, if that's their goal. The LEAD model also requires radically direct service, field-based guerrilla case management tactics, meaning that you meet people where they are in their circumstance and where they are physically and where they are emotionally and mentally. Project managers who truly inhabit the community and build deep understanding of its needs and dynamics. It requires cross-sector collaboration that generates new consensus based on ways of working, policies and procedures. The outcome, increased public safety and reduced harm. Naja? Next slide.
Thank you. So what we do definitely want to do is ground you in the history of LEAD. It's really important to know that LEAD really was the nation's first pre-booking diversion initiative. It's evidence-based model, which has gone through multiple rigorous peer-reviewed evaluations. And currently, LEAD is actually being replicated in over 80 communities across the United States, and that doesn't count the many, many communities there in Washington. And despite statewide support and investment, it's important to note that LEAD has not yet been funded to scale in any community, and that's something that we're always driving for. So LEAD started in Seattle in 2011 from a place of conflict due to the racialized war on drugs and the starkly disparate outcomes in law enforcement that was happening in Seattle. At that time, it was an organization called the Defender Association, which then began to become known as Public Defender Association, now known as Purpose Dignity Action. What ended up happening was TDA set the table with police and prosecutors and Black community leaders to complain and to call out the fact that there was so many disparities in the rates of arrest for people of color, specifically in the Belltown area of Seattle, which is just adjacent to like that area of Pike Place Market. And some of you might be familiar with what they call the Blade. So at that time, and this is about 2008, because it took a few years from the issue being raised to 2011 when LEAD actually got launched. At that time in the city, it was a city of about 6 to 7% of Black people, but over 60% of people in jail due to nonviolent drug offenses were Black, right? And so TDA at the time had issue with this. And so there was a lot of conversations and a lot of agreements that something needed to change, but that was only after TDA went through took pretty rigorous action against the Seattle Police Department and the district attorney at that time of King County. So after going back and forth for a while, everyone finally agreed to come to the table and agreed to the fact that there were obviously disparate arrests and different practices and policies that were substantially increasing the number of Black people who were in jail for low-level nonviolent drug crimes. So eventually, the civil rights groups, PDA at that time, it turned into PDA, and law enforcement and community members in Belltown came to the table and agreed to build something different. Now, of course, they didn't want to just build something that was saying, well, we'll just arrest everybody at the same rate, right? We didn't want that. They also did not want to just say, well, let's just arrest white people or non-Black people the same rate you're arresting Black people, because it was very clear to them that not only was there issue with disparities racially, but there's also just disparities around health outcomes and public health needs for people who were struggling with behavioral health issues and concerns and experiencing being unsheltered. They did not deserve criminal legal system involvement and didn't need that rotation through the system. So what they decided to do was to kind of take a break and go back and decide what they were going to do and what was going to be more, not less. They didn't want to just leave people there by not arresting them. They wanted to make sure they replaced it with something that was robust, that was helpful, that reduced harm, and that was going to be impactful. So what they ended up doing was utilizing a evidence-based harm reduction model, which is what LEAD is rooted in, to provide care and services similar to what Malika described earlier to this particular group of individuals as feverishly as as officers were arresting them. So the idea was, what if we were to replace the very high levels of arrest with very high levels of offering of something different, something that was less harmful, something that was useful, something that met people where they were, something that centered and humanized individuals, and something where people's actual thinking and autonomy is respected, and they're not just told what to do, where to go, and when and how to do it. So it was, this is when LEAD got formed, is they decided to challenge law enforcement and the prosecuting attorney to try this evidence-based model and this approach to work with this very, very, very hard to reach population, and a population that had been cycling through and missing a lot of opportunities and falling through many, many areas of the net. So in about 2015, 2016, a few years after LEAD launched, we started to get a lot of inquiries from across the country at the Seattle site. Can we come visit? Can we see what you're doing? Can you guys come to us and help? So right around late 2015 or 2016, what is now called the LEAD Support Bureau was developed. And it's just always been a mighty but small group of people who are responsible for fielding calls and inquiries from around the country from entities and sites that are interested in replicating, exploring, launching, piloting, and sustaining their own LEAD program. And like I said earlier, we're in about 80 to 85 sites around the country in states outside of the United States. In states outside of Washington, and we're looking at replication in Durban, South Africa. So thank you very much. And I will go ahead and pass it along to go ahead to the next slide. Can't remember who's next. I think it might be Malika.
Yeah, thanks, Naja. So 7 years ago, no, just joking. Anyway, but a long time ago, it feels like now, there was, and there still is, the criminal justice, criminal legal system, opioid overdose prevention work group. And it was at that time, there was a lot of conversation about what could happen in order to support the individuals in our communities that were experiencing the deep impacts of substance use disorder, and that continuing to arrest folks was not helping change the situation in a marked way. And that led to there being some recommendations put forward. And then the governor's opioid response bill in 2019, put forward that there would be pilot projects for LEAD to be started. And then there was also a recognition by the legislature that there might be communities that would want to develop an alternative response that is aligned to the LEAD model, but they might not have all of the resources in their community in order to do that. And that is where the Arrest and Jail Alternatives program came forward, or funding stream came forward. And that is run through the Washington Association of Sheriffs and Police Chiefs. And the governor's opioid response bill, that funding flowed through the Healthcare Authority. AJ, and then we have moved forward now with the Blake response, that R&P, Recovery Navigator Program, is explicitly based on the LEAD model. As many of you know, this is reflected in the state law. And it's worth bearing in mind that while the LEAD model is both evidence-based and has generated widespread support, it has not yet been funded to scale in any one of our communities that have launched LEAD. Naja, next slide.
Thank you. So it's really important as we talk about all the elements of LEAD to talk about golden rule number one. And this is super important because when we talk about centering participants and doing no harm, reducing harm, strengthening individuals, families, and communities, this rule is super important. And that is that no one can be worse off for participating. And you might wonder what that means. Obviously, no one should ever be worse off for being in a program, but because of the unique partnerships, collaboration that are in the LEAD program, it could incidentally or accidentally lend itself to setting up some circumstances where a person who touches LEAD might actually, if it's not clear that this should not happen, might incidentally have more contact with law enforcement or have a repercussion from the criminal legal system that would not have happened if they were never in LEAD. So some of these things might look like specifically for like between case managers and law enforcement. Like if they are at the operational work group or having a conversation, there should definitely be an understanding around the norms and how to appropriately use information that is shared, whether that is individually or that is in a group setting, because what we don't want is that the collateral information that is intentionally being shared from LEAD case managers or care navigators, from other behavioral health folks who are working with folks in LEAD, we don't want that to trigger a response by police to do a thing or trigger a response from prosecution to act on a piece of information they gathered that one, they would have never had information or would never had privy to had the person not been in LEAD. And two, that would cause the person more harm and maybe take them off their track of success or progress because I found out this secret piece of information that this person is still using drugs over here behind this building. I'm going to go arrest him and get a collar. So that's kind of a black and white, but that has happened and should not ever happen. The other thing is that sometimes officers will either use LEAD as a carrot to like reward people they like, or they use the threat of, if you continue to behave poorly, I won't give you this referral to the LEAD program. There's also been times when officers feel like someone is misbehaving on the street or doing the thing that they did to make him LEAD eligible in the first place. And they're like, can we kick him out of LEAD for talking back to me? So it's really important that LEAD is not used as like a reward for people that we like, and it does not serve as like a punishment or to be held over people's heads to shame them around their behavior or their struggles when it comes to issues that are being triggered or driven by their behavioral health circumstances. We also need to make sure that sensitive information coming from other behavioral health organizations or law enforcement or prosecutors are not being like targeted to the case manager. So there should be no intentional pressure to case managers or care navigators to divulge information that they know is protected by laws or HIPAA, or also could violate the sanctity of the trusting relationship between those two individuals, between the case manager and the staff. And then we also just need to make sure that when we're talking about the golden rule, that there's constant communication. You want to over communicate. You want to make sure that you're saying, I can't really say that. You have to find that on your own. There needs to be respect in all ways and go in all directions when it comes to making sure people are not worse off for participating in LEAD. The last thing we ever want is for folks and peripheral individuals who might be potential LEAD clients to not gain access or want to enroll in the program because they feel like their friends have gotten in the program, have actually incidentally received more assertion or more enforcement or had more harm come to them because of conversations that happened in spaces that should have been safe. So that's the golden rule number one. No one should ever be worse off for participating in LEAD. And the last thing I do want to say is No one should be worse off in such that someone gets punished for not taking advantage of the LEAD program. I have heard this happen before where prosecutors like, well, I referred him to the LEAD program and he has yet to complete or do anything. So the next time I see him, I'm definitely charging him. Again, that person is being held to a different higher standard because of being in the LEAD program and being seen as not using it or being efficient with outcomes. That would be another situation where this golden rule would be ultimately broken. Next slide. So I'm just going to run through the key methods of the LEAD model. One is field-based case management. People should be going in the field. Case managers, peer specialists, we want to go where our participants are. We want to provide care and services where they are, where they live, where they feel safe. For so long, services have been developed to make the workers feel safe and comfortable. And that has not worked and has not been the strategy that has been successful for LEAD participants. So that's really super important for people to be willing and dress for the weather and be in the mindset that they need to go out and physically meet people where they're at, not just literally meet people where they're at, not just figuratively in the sense of harm reduction. Collaboration. Malika spoke about it earlier. People who are in the LEAD program, it is a multi-system collaboration. There's communication going both ways between multiple people at all times. That is one of the key pieces of LEAD, is the collaboration allows for more creativity. It allows for reduction of harm. And lastly, it allows for the increase of success and long-term stability because of the collaboration and the problem solving that happens with those key stakeholders. We want to make sure the LEAD is community-based, meaning people should be in the community meeting. I might meet at coffee shops. I might take my LEAD participant to the doctor. I might go sit with them at a recovery meeting if they want company and it's in my schedule to do so. Had a case manager that took a participant to yoga class to do yoga with her as part of her recovery and as part of her mental health plan. She wanted to do yoga twice a week. So we paid for yoga classes. So it's community-based care. It's not office-based care. And in line with that, it's sustained. So I know you guys have heard that LEAD, people stay in LEAD as long as they need to. That's because the sustaining of care and not just dropping people or having people just fall through a net or reach a dead end, whether they've achieved anything or not, their time is just up, does not set people up for success. And it's a big reason why people have been unable to have sustained outcomes and be able to move in a process that matches where they are in their life to actually see results. And so having sustained system of care, having sustained community-based collaborative care, community and a conversation with other community members is essential to the success of participants in the LEAD model. There's multiple diversion and referral pathways. So in the LEAD program, and we spoke about this, I won't go into this too much. There was originally the arrest diversion in Seattle, which was at point of potential arrest. Then there was the social contact referrals, which was preemptive or proactive when an officer knew someone could use the LEAD program and would be really well served in the LEAD program. And then lastly, it's the community referrals, which is when community members who are aware of people who are struggling with being unsheltered, with issues related to substance use and other behavioral health conditions can then be referred into the program without there needing to be a fear of arrest or any kind of hammer or possible retribution if they say no or if they don't show up for an orientation. The other thing we want to talk about, and we spoke about this, and I just want to drive this home, LEAD is person-centered. LEAD is to be driven by the individual who's in the program. When care navigators or case managers are working with staff, super important that when they develop the individual service plan, they are not putting on there anything that did not come out of that participant's mouth. That participant gets to drive what they're ready for, if they're ready for, and what the steps look like to get there. There should never be a surprise if a participant asks to see their service plan and there are things on there that they did not say they wanted to do. Super important that we listen to folks that we listen more than we talk, and that we listen for cues around where that person's harm is, where that person's trauma is, and get them to start talking about what they want to see, or maybe a time in their life when it was better, and get them to talk about what was different then and what they did. So we are really, really not driving this car. We're navigating, but we are really, really helping them to like decide at the end of the day where they want to go. And we're just here to give ideas, to help them think about possible consequences, to help them explore different possibilities, but we are centering them the whole time. This is not about what we want for this person. This is about what they want for themselves. Lead has to be low barrier. That's easy. It needs to be accessible. It needs to feel safe. It needs to be consistent. It needs to feel like predictable, so to speak. So folks need to know if they walk into a lead space, they're going to be welcomed. There's going to be something there for them to eat. They're not going to be turned away. They can come as they are. They're not going to be told they have to get out because they have no shoes on or they smell a certain way. There's also low barrier in terms of I will go find a person. They're not required to come to the space, and that's back up to field-based case management. They're not required to come into space and look and present a certain way in order to get help. And then lastly, systems change. We have to remember at the end of this, we are looking for system change. It's great and wonderful to change individuals, to have an impact on communities and families long-term. But one thing we want to do is we want to go push up higher up the river to start talking about changing systems and start changing how systems see folks that are struggling, how systems handle folks that are in need of actual care and actual response, and not just basically discarding people and marginalizing people and further displacing and alienating people to the point where they actually feel like they don't even belong or don't even deserve to have all the other things that many of us take for granted. So we really are striving at the end of the day to change the criminal legal system, to change public health systems, to change all the behavioral health systems, to think of this lead approach as usual. There should be a day when this approach isn't unique, where this approach is the standard of care across all criminal legal systems and in all communities. I'll leave it there. Next slide.
And now we'd like to talk to you about the site development tool. And the lead model is adaptable. It's an adaptable model that's designed to reflect your hyperlocal context. Through the implementation of this model and many, as Naja has mentioned, peer-reviewed research episodes, we have recognized that community and political priorities are a part of that planning process, system capacities, and geographical and jurisdictional reach. Sorry, I just muted myself. And the LEAD site development tool was designed specifically for LEAD and LEAD aligned initiatives. This site development tool is intended to support sites in identifying areas for improvement and tracking progress for LEAD implementation over time. The tool is aligned with the LEAD Fidelity Framework, a resource defining the key elements of the LEAD model. The site development tool includes 3 parts: a questionnaire that guides LEAD staff and partners through an assessment of key elements of their initiative, a workbook summarizing the results, and a LEAD site development plan. Next slide, please. And as we said, it is an adaptable model. However, there are some non-negotiables elements, and that's the shared governance focused on changing systems, including realigning resources, commitment to reducing disparities, collective responsibility for coordination and implementation. Next slide. Having an empowered project manager or project management available. Long-term, intensive, field-based, participant-centered, culturally aware case management, and voluntary for participants to engage in. There are no mandates or time limits. I think all of us can agree that self-directed change is much more durable than imposing our will upon others. Next slide.
So LEAD is a framework of shared governance, partnership, and accountability, and it moves at the speed of trust. And that's really important because this is a partnership across sectors, right? Like I mentioned towards the beginning, it is a cast of partners that, typically wouldn't be in a room together, right? Social work, law enforcement, prosecution, elected officials, community leaders, and civil rights groups. It's an unusual group that typically is not in a room talking about individuals or sort of, you know, less than we would like sort of problem solving, and it's necessary to see real change. And so trust is an integral piece of that. And you're only going to move so fast because trust is something that builds up over time, right? It doesn't magically happen because you have a piece of paper signed, right? That's an important part of it. And I'll get to that in a second. But really, you'd build trust over time by continuing to have conversations, by continuing to show that you're going to hold to your word, that you are not going to make a participant worse off, right, as a prosecutor or a law enforcement. And then on the other side of things, on the social work side of things, you continue to prove day in and day out that you are going to be, as transparent as you can be, that you're not going to leave things out, that you're not going to mislead or sort of lie by omission. And as time goes on, that trust increases, and then that group is able to do, increasingly more intimate work together. And these partnerships can only occur with the appropriate written legal documents, right? That is sort of the bare minimum, and then trust is built upon that. So first there is the policy coordinating group, which I think both Naja and Malika mentioned, right? And that policy coordinating group, or PCG as we sometimes call it, acts as the board of directors for LEAD, right? So if it was an organization, you have all these parties, all this staff, and then at the top is this board of directors. And that policy coordinating group can only be formed with a signed memorandum of understanding between all those entities. And then in addition to that signed legal agreement, there's a multi-party release of information, or ROI. So participants must sign an ROI that names all these entities. Otherwise, case managers are not legally able to share this information that's needed. They have to have that ROI signed, and then when that's signed, they're able to share information for the purposes of helping the individual. And that's always the reason that case managers are able to share is because they have the belief, based on these signed agreements and based on the increasing trust, that ultimately the information is shared for the purpose of helping that individual. And then third, as far as what's written, are protocols and like other policies that are written and regularly revisited by the policy coordinating group. So there's a set of, sort of like, a policy manual that shows how the work actually gets done. That comes into the form of protocols and other policies that everyone follows. And so all of this is tied together and tied together and held together, and emphasis on held together, by a savvy, trusted, and independent project manager. So, this program, because there are all these disparate entities with disparate interests, and frankly, like meetings and protocols and communication sharing kind of requires a quarterback. For those of you, if you'll forgive the sports analogy, kind of requires a quarterback in the sense of like, or maybe a offensive coordinator. I don't know. I'm really taking this analogy a little too far, but need somebody who has, the whole vision in mind and can sort of make sure that it's held together and that folks are sort of working together throughout the process. So next slide. So as I've sort of alluded to, and we have alluded to, there are two meetings that are integral to power shifting and power sharing. And it's all rooted in relationship and mutual respect, which, by now I hope you see is a really common theme in LEAD. So first is the policy coordinating group, and here it's written as policy working group. And, again, board of directors, governance, and because it moves at the speed of trust, it takes time. But it should, as a group, move when there is broad agreement among the group, right? So because it requires broad agreement amongst the group, it may, shift a little bit at a time, but that's okay. And that's sort of part of the process. And then in addition, there is the operations work group, or OWG, and that's day-to-day operations. So, the operational partners are coming together on a more regular basis than the policy coordinating group, and they're discussing the day-to-day stuff. So monitoring, discussing, and addressing participant-specific issues and program operations. So policy coordinating group is like up a higher level of sort of like, how do we operate? How are things going? And then the operations work group is really getting down to the level of participant-specific issues and program operations. And the operation work group is using the protocols that are established by the PCG to sort of determine how that work is done. Next slide. So with that sort of overview done, I'd like to introduce you to the fantastic lead Washington Technical Support Team. We have Lisa Dugard, who is the co-executive director of policy, and this is one of her primary areas of responsibility. Patricia Selly, who is my other fellow deputy director. Malika Lamont, who you all know well, Director of Washington State Technical Support Team, and then Shelley Wilder, Project Manager for Washington State Technical Support Team. And then as you can see at the bottom, there's a list of folks, and the team works with and integrates expert practitioners that have their own particular expertise that may be helpful in the work that an individual site is doing, and they can provide sort of feedback and guidance based on their particular expertise. So with that, next slide. With that sort of concludes our presentation, and we can open it up to questions if anybody has them.
Yes, questions for the lead group. Go ahead and raise your hand virtually and we'll call on you. Julian.
I just want to say I'm really impressed with the thorough program you guys have. It's like I always heard about LEAD and I had hesitation to listen. I wish I would have known this sooner. I love it. I love it. It's so thoughtful and so person-centered. I love it. So just want to share that.
Thank you for saying that, Julian.
Thank you, Julian.
Any other questions or comments for the lead group? Okay, thank you so much for your presentation. Tony, you want to say a couple words here?
No, just echoing what Julian said. Although I mean I was really familiar with the Brandy, go ahead.
I do have a question, and I have to say, I work on LEAD, so you could take my question how you want it. But since we have some of the national folks and the state folks in the room, what do you think it would look like if we were able to take it to scale, and how would we get damaged if these budget cuts go through? Like he said, it's a brilliant program. It's great. I wish I knew it was there. It would look a lot different if it wasn't funded or wasn't around. The system, the community would look different if LEAD was eliminated. So what are your guys' thoughts on if it was eliminated, and what are your thoughts on if it were able to take the scale given the current drug supply and behavioral health issues we're facing in the community? What could LEAD be remarkable in?
Well, I have one answer I'll give with regards to it's one small piece, but I'll leave it to Malika and Naja to explain more. But I think the real risk in one of the big risks in elimination is, because it's a pre-booking diversion model, it's sort of an outlet valve, a way to like not overwhelm and tax the system. And so I think if funding decreases or the program is eliminated, then that just means that the criminal legal system is even more burdened. And those people that have been diverted or their criminal legal, the behaviors that might lead them into the criminal legal system are going to continue to exist or continue to escalate. And, the system continues to be taxed. But with that, I'll hand it off to Naja or Malika.
I agree with you, Brandy, that, it is a pressure valve. I also think that we need to think of it as, it is oftentimes a better alternative than business as usual. And although it is in some ways costly financially. The return on investment is much more than what we see with incarceration. So it's like if we don't even take into consideration the human impact, but we take into consideration the financial impact, if we're just talking about finances, that is one of the things to think about. If it was done to scale, I think that it would also require us to think about all the things that people need in all the areas of their life that scale needs to be increased as well. As you're familiar with, Brandy, having a legion of case managers, but no services for people to get into is not as effective as it can be. So I would encourage us all to think about LEAD as a crucial piece and helps coordinate care around our most vulnerable. And we also need to look at what are we lacking across the board in our communities in order to be able to support the most vulnerable and to support everybody in general, frankly. So, these are the things to think about from my perspective.
I just wanted to I want to piggyback on something that you said, Malika, about communities. I think everything that Brandy and Malika just said, and I think I'll do a little bit of a dream. In a dream world, we need is scaled. I think what you have is you have enough housing, you have enough services, but you also have people feeling like they belong again. You also have communities that have a deeper understanding and recognize the harm that was caused and are willing to step in to help support and to help provide services to help who are actually their community members. So you start to have that community where we talk about a long time ago when people used to take care of each other. Like, I think if we were to go to scale, in addition to all the things that have been mentioned from a system standpoint, I think you have people that feel less traumatized and feel less alienated and feel less like they don't belong or that they could just wither away and disappear and no one would care about them. So if LEAD were to be scaled in the way that I feel like it should, people would have more visibility and people would see people way more than they do right now. And people wouldn't be walked around and stepped over in the way that they are right now around the country.
Thank you. We have one more hand up. Are there any committee members before we get to that hand that want to have a question or comment? Okay, we have got somebody on the phone here for a quick comment. We are actually over time, but this is very important. So, caller.
Yes, hi. This is Sheriff Tanksley from Whatcom County, and I had to switch to my phone. I don't know if you could hear me or not.
Yeah, we got you.
Yeah, so I just wanted to ask about the comments that were made with regard to law enforcement using the LEAD program for some people in terms of some type of retribution or threat. And I'm sorry to hear that, and I apologize for the entire law enforcement community. But my question is, in those cases, because I've never heard that before, were the agencies where those officers worked, were they contacted and was that dealt with, or is there any follow-up on that?
I can respond to that, at least nationally. So it doesn't happen a lot, but it happens enough to where you have to imagine that if it happens in the context of this program where officers and participants and our citizens on the street are working together, citizens who have traditionally been targeted by enforcement, that if it just happens once or twice, it could take a whole program under, right? Because of the word of mouth. And so what happens is just a conversation. Like, there's just like, hey, we can't do this. Remember why we're here. It comes back to that collective power sharing and that collaboration and just moving at the speed of trust and just continuing to presume the best and that it was a mistake and to remind folks about why it's important to not do that and the harm that can happen and how it can like take away a really wonderful resource and approach if it happens and nobody wants to participate in the program because everybody feels like they might be worse off for being a lead than just going it, so to speak, on their own.
Okay, thank you so much. I appreciate it.
You're welcome.
Again, thank you so much for the presentation. Appreciate that. We're going to go ahead and give up the committee member announcements, that 5 minutes at the end, but that's all good. Appreciate the information. Tony, you have anything to take us out?
No, just great questions, great presentation. Been working closely with the Lead Support Bureau since 2018. And just I learned something new about the model. It's a very nuanced, complicated, detailed model, but there's outcomes associated with it that point towards how this is a way to change systems that have been around for decades that we know don't work. And so just really appreciate Brandy, Malika, and Naja coming in and sharing this information with the group. Thank you
so much. All right, next up we have PDAMS, Program Data Acquisition and Storage System. Cooper, you there? And Tony, you have any comments before we get into this?
No, we had referenced some kind of big acronyms in the past, like EDIFEX and PDAMS, and it all kind of falls under the healthcare authority's goals for data collection, data validation, data storage. We have a data strategy plan. I believe it's like a 5-year plan. And one element of that is what Cooper is here to share with us today. And so I'll hand it off to Cooper, but just kind of, yeah, it felt like this was relevant background information because some of these things have been coming up in our conversations about Recovery Navigator program and other questions that we've heard from the committee, like how can we track somebody between programs? Like if they're engaging with SUD Family Navigator in one program, or that's not a bad example, but host in one day and then maybe engaging with R&P and next day, like how are we like kind of understanding the way somebody moves through the community behavioral health system? And so I think this is one way that kind of at least gets us moving or inching in that direction. And so Cooper, thanks so much for being here. I'll pass it off to you.
Yeah, thank you. Thank you, Tony. Hello, everybody. And good morning. I'm Cooper Wright. I'm the DVHR Behavioral Health Data Administrator. At high level, I'm going to go over DVHR's PDAMS solution. And PDAMS is it's our solution to address inconsistencies when collecting data with spreadsheets. In the previous few years, as programs have matured, we've tried to move away from collecting data on spreadsheets, mainly because the freehand nature has led of entering data into individual cells has led to confusion and variations, and that confusion and variation leads to issues when trying to conduct analysis. And just to kind of give you an idea of what I mean by variation, I'm meaning that between all of the providers submitting data, we might have one provider submitting for a client that's male would enter M, like a capital M, and another one would enter the entire word male but with a capital M, M-A-L-E, and then yet a third one would be a lowercase M-A-L-E. And the problem is that HCA, for data integrity issues, can't go in and change those data points, even though it's patently obvious that they all mean the same thing. We can't make any changes to the data that we receive. We've had some success in actually implementing PDAMS. The TrueBlood programs, FHARPS, FPATH, and Crisis Housing Vouchers are all on PDAMS right now and collecting live data. CJTA and HARPS are due to go live in the next coming weeks. We have several more programs in the pipeline. One of them being Recovery Navigators in what we call the discovery phase. But I will go into more of that. I'll go into that more later. PDAMS, unsurprisingly, is an acronym for Program Data Storage or Program Data Acquisition, Management and Storage. But it isn't just one software solution. PDAMS is a process of collecting data with two different applications in series. As depicted in this diagram, data is first ingested by structured data capture and then processed by XEngine And then finally, the data is stored in an operational database after it's gone through those two different software solutions. Our goal is that once collected, the healthcare authority will accrue data that is formatted, accurate, and ready for analysis. Structured data capture serves as the immediate interface with a data submitter and can take two paths to capture data. The first is a website-based solution where providers enter information as clients are treated, and then that data is automatically submitted to HCA. The second method is a bulk ingestion process where providers can export comma-delimited files from their electronic health record software and make it available for PDAMS capture. And here's an example of what a data entry form can look like. And, it looks very clean. Everything is set. Most importantly, though, is this notice, or I'd like to just notice the use of drop-down menus. What that'll do is that'll eliminate any kind of ambiguity in entering data, so that from one service provider to another, they're all selecting the same input for each service as they're rendered, and that'll go a long way to helping out with analysis. Once the data has been captured, X-Engine takes over. X-Engine conducts a data validation protocol where each individual data point that is submitted is compared to a set of criteria that has been established in the discovery phase. If the captured data passes X-Engine interrogation, it is allowed to move on to the next phase. However, if the data does not pass X-Engine, a notice is automatically sent to the submitter with a log of data points that did not meet the criteria, and prompts the submitter to make their data points align with the established criteria. And if you wanted to think about it, X-Engine really acts like a screen, an automatic screen, that a function that would fall onto the program management at HCA. And for all the spreadsheets coming in, it was just a lot to ask. So this PDAMS will make this process a lot more automatic. And here's an example of an error report. And if you notice underneath the error column, it identifies the reason for the error and gives it a severity classification. And this is where we want to go as HCA. The onus has to be on the data submitter to ensure that the data being submitted is ready for analysis. That way, HCA does not need to do any touch-up to the information we receive, and preserves the data's integrity. Once the data has passed through PDAMS, it is then stored on the program's operational database, like BHDS or another storage location. From there, HCA can develop reports to submit that can support the program's mission. While the data does not immediately move to the enterprise data warehouse, our plan is that once the data has been collected, it does eventually move to the EDW after it's met a certain criteria of being housed at HCA. But that criteria for moving to EDW, it will be established for each individual program. However, it requires a lot of work and coordination to get to that point of formatted, accurate, and clean data. In the broadest sense, as each program moves to PDAMS, DBHR takes the opportunity to ground ourselves and assess the data needs for each program. It is my role to meet with program managers like Ryan Keith to develop a set of business questions to be answered by analysis. Questions such as, who uses our program, which providers served them, and what services were provided. From that list of questions, DBHR works with our in-house data divisions to develop a list of metrics required to answer the business questions. And once those metrics have been identified, our Enterprise Technology Services Division begins constructing a PDAM solution that is specifically fitted to each program. In the example of recovery navigators, it includes meeting with service program service providers and other HCA program partners with questionnaires and interviews to learn about the current data collection processes. But the coordination with data program providers does not stop there. After the first draft of a PDAMS solution is ready for testing, HCA conducts a validation process and encourages feedback. Service providers get an opportunity to test out the new solution and hopefully return notes on how to make it work better for them. PDAMS is a great opportunity for data collection, data pain points to be addressed, and our aim is to make this process as seamless as possible. One last point is that PDAMS will also make reporting more available, not just reports to the legislature or other partners, but to ASOs and service providers too. Our hope is that reporting will make programs more efficient and result in better services being provided to the public. As noted before, Recovery Navigators is in the discovery phase, which means we're in the process of meeting with ASOs and data submitters. And we're looking forward to moving forward very fast with this program. And that's, anybody have any questions?
Questions for Cooper? Please raise your hand digitally. All right, Caleb.
Hi, Cooper. Thanks for that. I think I got some of that. It seemed like a lot of that was about data validation, is what I was hearing, and I understand data quality is going to be really important, particularly in these sort of broad, disaggregated service provider groups and such. Can you tell us more about the timeline or where we are in terms of meaningful data output? For instance, to answer some of the questions, maybe looking to Tony as well. I have to run around all these different data. Thanks.
So the data timeline is dependent upon each program. So it's going to be as programs come online, the data will become available. The sooner the better. Did you have a particular program to ask about? Is it Recovery Navigators? If it is Recovery Navigators, we do have this is not a weeks-long process or a months-long process. This is quarter-long process, and it's not just one or two; it's several. I would imagine maybe by the end of the year we would have a good solid process for Recovery Navigators.
Yeah, Cooper, I think also, Caleb might have been talking about looking back at slide 8, the awesome kind of infographic, like the weekly, monthly reports, what it will look like once data are collected, are validated, synthesized, stored, and then what does the reporting process look like? But
yeah, so that's kind of one of the nice processes or the nice results of this whole process is that each program will be able to design those for themselves, so that if on a whole the program, all the service providers want it quarterly or monthly or weekly, will have that kind of information. That also depends on how fast we collect the data. If every program is submitting it via the web-based form as services are provided each day, that'll obviously mean that the reporting can be quicker. But if there's a lot of providers who are using the batch process where they're getting a report from their EHR every quarter and then submitting it every 3 months, that's when that timeline will play out. But it's all really dependent upon the priorities of the program, and that's the kind of thing that we identify during the discovery phase. And what I mean by trying to make the data process work for providers.
Okay. All right. Thank you so much, Cooper. Appreciate that.
Thank
Tony,
you.
you have anything you want to take us out on?
No, Cooper, thanks so much.
right.
We might bring you back for a subsequent presentation in the future, but thanks so much for being here and putting this together and sharing that update.
No problem. Thank you.
All right. Next up, we have RMP highlights, and this might take us to the end of the meeting. So, Tony, you want to introduce this group for us?
Yeah, it's great to see Ani King, who I've worked with and known for coming up on a decade at least, I think. And, you know, it was funny when Malika was talking about the criminal justice opioid work group and the work around the opioid response bill. Ani was with DBHR at that time and was mentoring me and having those initial conversations. So this is really fitting and a great segue. And so Ani is now with Carillon, left the state and went, unfortunately, but fortunate for Carillon, and is here to share updates about the Recovery Navigator program in the Pierce County region. And so, Ani, I will pass it off to you.
Thanks, Tony. Good morning, everyone. Ani King. I am a project manager at Carillon Behavioral Health here in Pierce County. Yes, I've had a long experience working with the state in several different organizations. And thanks, Malika, for your shout out in the chat box. One of the many programs that I oversee is the Recovery Navigator program. We have been up and running with Recovery Navigator here in Pierce since November 1st, 2021. I'm really excited. We've got Pierce County Alliance here on the call. They oversee Recovery Navigator across our entirety of the county. And Amy is here somewhere. There's 73 people, so I don't see her, but I know she's here because we've been texting. So I'm going to pass it to Amy.
Thanks, Ani. Max and Cassandra are also here. There are two program managers, so they supervise our staff. And I know they're here. I don't see them. So they're here. Ani asked me to gather up some success stories, and so I asked Max and Cassandra to write those up for me. What strikes me about what they've sent me is that they sort of represent the continuum of intensity and case management that people come to us needing. So I'll give you a short-term, sort of less intensive case management success, and it's a young woman who came to the Navigator program homeless, living on the streets in a tent, and she was presently non-compliant with probation. But once she got a Navigator, she was able to secure housing, got into outpatient SUD services, and is now sustaining her compliance with probation. And what she would say her biggest accomplishment is at this point is that she was able to successfully apply for FAFSA and enroll in college. And so we don't hear from this person in a real intense way. It's check-ins from time to time. And, you know, if something else happens, I'm sure she'll come back. But it's an in and out. We've been able to connect those services, and people are able to fly on their own. A more intensive and ongoing, it represents even more than just case management for that person and connecting them to services. It represents an ongoing collaboration with service providers and the courts. And this is a older woman who has been known by the Pierce County Prosecutor's Office for several years. She's been in and out of inpatient treatment. She came to us with untreated serious mental illness, inactive addiction, and was actively putting herself in harmful situations. She was petitioned and put on assisted outpatient treatment and has been doing adult outpatient intensive SUD treatment as well as mental health, and has a navigator who helps coordinate all of those teams. The client is actually moved into an adult family home, goes to her SUD treatment groups, doing all kinds of pro-socials, including the local recovery cafe. She goes to church, and she engages in 12-step programs. Prior to this, she had been in and out of our local mental health hospital many times. But since she's come to us and she is in an adult family home, there's been no uptick. Everything's going smoothly. She manages her own schedule and gets around town with public transit. We anticipate continuing intensive case management and wraparound in collaboration with service providers, at least until she's out of the assisted outpatient treatment program. And even then, after that, we don't have a time limit on the services that we provide. So as much or as little and as often as people want to meet with us, they can. Here's an example of sort of gap filling. We had a young man with multiple successive misdemeanor charges that were all precipitated by untreated serious mental health or serious mental illness. He had been working on getting Social Security disability for a really long time to sort of address what he saw was his unmet need, which was the ability to, have appropriate clothing for the weather and groceries. He has not been able to sustain a job. He was unsuccessful in multiple attempts at SSDI, but after working with navigators, he was able to complete and submit the paperwork, get the appointment, and has now been approved. He's also been able to secure services at an adult family home, and he maintains intensive wraparound case management services. So our navigators are really providing those day-to-day peer interactions to keep people engaged. Other examples, here's one from a law enforcement diversion. The referral came from the local police department. This was on the eastern side of the county. So the local police department, the officer called and said that some local businesses were asking for police support. The person appeared to be in active addiction. Instead of citing or arresting that person, the officer called us and said, I don't want to trespass or give a ticket for disorderly conduct. Can I bring the person to you? Of course, we said yes. So at the time, the client agreed to come and meet with navigators on the phone when the officer had called us. The officer dropped the person off at our office. We spent about an hour time with the person, and we were able to secure a detox bed. And so the person actually, and transport them there. So the person actually went from being in the business mind, a nuisance, to getting to a detox bed and getting connected with services. I have another one. This is sort of peer support, resource navigation. The person doesn't really need intensive hand-holding or ongoing coordination or case management. The person is actually in a therapeutic court program and had a suicide attempt. But since then, they've connected with the Recovery Navigator program and the case manager with the local housing authority, and we were able to get that reinstated. So now, with the help of the navigator, they're able to gather up all of the documentation and intent to rent, W-9s, all of that, and connect the person with a source of funding for move-in resources. The person is successfully housed, has scheduled an SUD assessment, specifically, this is another East Side, specifically at Pierce County Alliance, and we're in downtown Tacoma, because they said that having the navigator there was, quote, the biggest blessing, and that they had recently reported that they were adamant about going to treatment, and it had to be Pierce County Alliance because of the experience they had with the navigator. And I love that. As the COO of this agency, I love to hear that kind of compliment, but I want to assure everyone that we would never require anybody to come to Pierce County Alliance. If they want to be here, we'll make it happen. If they want to be somewhere else, we'll make that happen too. So no requirement to come and get any of our clinical services. Then just a couple of systemic successes from the East Side, which, inherently was different for us because we operate primarily in downtown Tacoma. So we're on a learning journey as well as our clients. But we've been working with the Bonnie Lake Community Court and the Puyallup Community Court. So we've had at least 3 Bonnie Lake Community Court folks avoid eviction by working with the recovery navigators to identify housing funding that's available to them. We got somebody with an extensive criminal history with both SUD and mental health concerns. We secured evaluations for them. After they had what they termed a negative experience with an agency closer to where they live, but they were willing to give another treatment agency, a chance because the navigators were so accessible and welcoming and non-judgmental. So now the person is also working with the RMP to access all of the public benefits through DSHS. And they've previously been unable to do that because they're so far out of a city area. Since November, we've helped 4 people on the east side obtain their driver's licenses, which doesn't seem like it's a big deal, but it's kind of got to schedule an appointment and figure out your transportation and figure out how you're going to pay for it. So our navigators are always able and willing to do that kind of just putting those pieces together for what seems like small things, but open up the world for people. And those are the current success stories. We've got years of them now. If there's any questions.
Questions for this group? Go ahead and raise your hand. You have questions? All right, Malika. Thank you.
I was wondering, can you share with us what the demographic breakout is of the people in the last year that have worked with, or just to date, of the folks that have worked with Recovery Navigator program in Tacoma?
Yes, less than half of them are white. The rest are across all the people of color and ethnicities that we collect.
Age, what? I mean, demographics is more than race. I just meant like age, kind of.
Sure. They range in age from 13 up to late 60s, though heavier in what we would assume the bell curve of age would be. So heavier in the middle age, very few young people. It starts to pick up in quantity in the early 20s. Most of them are in the 30s and 40s.
Okay, thank you.
Oh, I will say many of them identify as gender or sexual orientation that are not collected on the data sheets. So we do see a lot of those identifying characteristics, self-identified characteristics as well.
Thank you.
Any more questions? The Pierce County Alliance, folks. Okay. Thank you so much for your presentation. Tony, anything you have to say to take us out?
No, just Amy, nice to meet you. And thank you so much for sharing those awesome success stories. It's great to hear that even though, RNP and PCA are located in the downtown Tacoma area, that you're going out to Bonnie Lake and Puyallup. And so great to see that sort of kind of outreach and geographic catchment. And I think it points to like the earlier question about like scaling up and how to scale up, or, if funding was reduced for a program like this. I mean, Pierce County is huge. It's a large county, and it's got a lot of cities, municipalities, and there's a lot of rural areas. And so it just gets me kind of thinking about how to like capture, like to what extent like we have geographic coverage as opposed to, kind of more centralized coverage with some of these programs. And I think that's a great example of how PCA and the RNP program in Pierce County has at least started to kind of branch out and work with other communities. So.
Thank you.
I would
be remiss if I didn't say, hey, we go to Key Peninsula too. So both sides.
I also want to throw out that Pierce County Alliance has a satellite office for the Recovery Navigator program in Puyallup, right behind the TJ Maxx.
That's new, that offsite. We are physically expanding.
That's awesome. Well, thank you. Thank you both so much for being here and for sharing that awesome, great information. It's great to hear some of those outcomes associated with the program, especially after last week was full of so much difficult information and updates. And it was just, so it's a good way to start the week. And so hopefully that's a sign of what the rest of this week will be like.
Thank you.
So I don't know where we're at with the agenda, Blake and
I
Kelly. So
think
I don't know.
that
Maybe we
have
got
a
10
little
minutes.
time for, we have a little time for any comments from committee members about anything that they've thought about during the meeting or want to announce, what have you. So,
Real quick, while kind
yeah.
of committee members are thinking about any updates they want to share with each other or those in attendance, I just want to flag what Robin indicated in the chat. And I'll just quote what Robin said. I definitely wouldn't minimize the success of getting individuals licensed, Amy. In the Great Rivers region, we did a preliminary informational report on potential cost savings from just getting individuals new or reinstated licenses. Small steps for some, but huge potential compounded impacts and savings in communities. And so I thought that was important to kind of flag and call out because that is it's a huge barrier. Even I've been helping my mom try to get her license back for the past year, and it's she calls me every other day and struggling with either working with the prior state's DMV or Washington's. And so I was just glad that Robin kind of flagged that because it's not a small thing. It's a huge thing. It's a huge step and it's a great success. So thank you for putting that in the chat, Robin.
Okay. All right. So any comments from SURSAC members? All right. Thank you. Any public comment? Anybody from the public want to make a comment? Go ahead and raise your hand. Okay. I see no hands. So Kelly, I'll turn it over to you to talk about next month.
There's a new agenda that's been generated by HCA, just the format and such. And so I'll be using that. And so I don't have anything to present for March as of right now. But March, I believe, is going to be RMP quarterly report for March. So I think I could be wrong on that, but I don't have anything in front of me. But yeah, so I'm going to be using the new agenda that came out, and so I'll be sending that out to everybody. But in the chat, I will be going ahead and I copy and paste all the stuff from the meeting today, and it has all the links and everything that we talked about today, and you can go there and get whatever you need for what happened in the chat today. Oh, and also great presentation by Lee. It was really just interesting to hear everything. And I'll go ahead and pass it off to Christopher if Chris, if you're still here, if you want to make an announcement real quick.
Sure. Yeah, thank you. I put the link in the chat. I just wanted to let everybody know that the State Opioid and Overdose Response Plan Learning Community Meeting 2025 series has been scheduled. There's a link in the chat. You can register for all of the meetings there. The next meeting is this week. It's at 10 a.m. I'll be giving an update on some of the state's activities. Probably we'll talk a little bit about what's going on with the legislative session, and also we'll have the Attorney General's office will be there for an update on some opioid settlement news that we've been hearing. So that'll be the meeting this Thursday. This year, there are only 1-hour meetings. We were ending early most of the time last year. So we created a series as a series of 1-hour meetings now. So yeah, just feel free to register and hope to see you there. Thanks, Kelly.
And even though thanks Chris for that update, and Kelly, thanks for collecting all of that information and putting it in one nice spot in the chat, because that chat does get kind of long and has a whole bunch of info. So appreciate you doing that. We have 5 minutes left, and so just kind of flagging and thinking about the March meeting, we have the RNP data presentation scheduled, and Caleb, the questions that you had sent in regarding kind of staffing and the scaling of the program and some of those other ones, we're working through those. And so hopefully we'll have a little bit, be able to address some of that during the RNP data presentation that Brianna Peterson will be doing. And then I think, well, we talked about a legislative update. And so we will make time for that. And then Kelly, do we have anything else? I know we don't have an agenda, but do we have anything else that's on our kind of SharePoint tracking sheet that we had planned for March that we can kind of flag now?
No, and I was just looking at it. So for right now, it was just the RMP quarterly report for March and RMP highlights and such and so.
Then I think if the committee is amenable, we could have RDA come and present on the filing data pool that they did. And it may be a combination. I'm meeting with Office of Public Defense and RDA later this week to talk about a couple different data pools from the Administrative Office of the Courts and that RDA did, specifically looking at the prevalence of unlawful possession of controlled substance filings across the state. RDA even kind of drilled down to the law enforcement agency that is like the arresting agency on file for those charges. And I know this is something that we've talked about, and it sounds like since there may be time in March, that we could kind of plan to have that, open both a presentation looking at like filing data across the state, as well as just kind of like feedback from the committee members like Chad and John about like what they're experiencing as a prosecuting attorney and a defense attorney in the state. And we can also have Office of Public Defense share some of the work they've been doing and what they've been seeing around State versus Blake. Grace O'Connor's been, has suggested and has offered to do that. And it's just, we've been having a hard time fitting it in. And yeah, it just feels like if there's time and we don't have a full agenda yet for March, we should look at that and have that conversation sooner than later, especially in light of where we are with the legislative session. And so, just if we want to do I don't want to, any thoughts about that? I see Malika said, I like this idea. Is there data on public use? No, I don't think we looked at that, but we totally could. So let's make a note of that, and I'll check in with OPD and RDA on that one, Office of Public Defense and Research and Data Analysis from DSHS. I saw a thumbs up from Caleb. Caleb, would it make sense to also look at the toxicology lab data at that same time? Would that give us any other kind of perspective? Like the WSP, the Washington State Patrol Tox Lab.
So there's two different aspects of that. There's just the sheer counts that we're seeing, which when things are getting submitted for prosecution, but that's super discretionary. And I think the data you're looking at are kind of upstream of that and probably easier to interpret. The other thing is, which substances are actually being seen, but that sounds like a different topic. So I'm not sure it's helpful, and you could look at it in addition to that, and we can just have the simple counts. But I don't know that it's worth getting a lot of data.
Great. Okay, well, Kelly, let's go ahead and put that as a, hearing no opposition and hearing some support. We can put that as kind of, and I think between those three, that's a pretty full agenda. It's going to take a while to talk through all of that. But great meeting. Thanks, everyone. Seeing that it's 10:59, I'll just kind of take us out at this point since I'm already talking. Appreciate everyone showing up today, making time to spend 2 hours talking about these really important issues. Thank you to our guests and presenters from the Lead Support Bureau, as well as the Pierce County Recovery Navigator Program and Carillon. And thank you to Cooper as well for sharing updates about our data strategies and the PDAMS solution. Please, if you have to drive and commute anywhere today, stay safe and drive slow. And then again, I'm just going to say it again, just because looking outside and looking at the weather, just thank you to all those that are providing direct services in the state, supporting individuals experiencing homelessness and getting them connected to services. Always important, but especially important when it comes to potential issues that come from inclement climate situations. So thank you all so much, and appreciate you, and we will see you next month. Take care.